good evening, and welcome to this wonderful production we have here on blackdoctor.org. I am Ellis Dean, the Director of Programming here at Black Doctor. And again, this is Seeing Eye to Eye. This is our monthly program in partnership with the Children's Vision Equity Alliance, as well as our friends over at the National Eye Institute, where we bring you programming all about your vision. So we've had optometrists and ophthalmologists and all type of vision specialists coming on talking about a variety of vision issues. And so if you've missed some of the programs about glaucoma and all those other things that we talked about, we encourage you to go back to our YouTube page or go to our Facebook page and search and find those programs. But don't do that right now, because we've got another fantastic program here for you. Tonight is all about your child. My child can't see. Why and what should I do? And so that, as a parent of two children myself, I think that if my children came to me and said, or I realized my child could not see, it would be devastating for me as that parent. And so we're going to give you some really tips tonight of what some of those causes of vision loss in children may be. And then we're going to give you some help on what you can do and what you should be working with your provider. I will say at the beginning, before I introduce our illustrious guest, that this is for informational purposes only. If you are seeing a ophthalmologist, or if your child is seeing an ophthalmologist, please follow their treatment plan that they have set for them. This is just to give them some options. And if what you hear tonight is different than what you've been hearing from your specialist, ask the question, but still have that conversation. Do not change or stop any medications or change any of their treatment plan as a result of what we're discussing tonight. So this is to help you become a better advocate for your child and for your family, but not to be in replacement of any treatment plan that they have in place. So I have to say that up front, because I wanted to have any problems. So let's get to who our guests are. First, we have Dr. Donsunu. She is a board certified ophthalmologist and associate professor of ophthalmology at the Abrahamson Pediatric Eye Institute at Cincinnati's Children's Hospital Medical Center, University of Cincinnati in Cincinnati, Ohio. Dr. Donsunu specializes in pediatric ophthalmology and strabismus. Boy, y'all know these words. I'm telling you. She completed her fellowship training at Duke University Eye Center in Durham, North Carolina, and completed her ophthalmology residency at the Mayo Clinic in Rochester, Minnesota. She received her medical degree from the Ohio State University College of Medicine, where she graduated cum laude and her undergraduate degrees in chemistry and liberal studies as a summa cum laude graduate at Kentucky State University. She currently serves as a director of medical student education for pediatric ophthalmology and as the pediatric ophthalmologist for the Charge Syndrome Center, so at the CCHMC at the University of Cincinnati. She serves as the secretary for ophthalmology section at the National Medical Association. Her research interests include describing and treating the ophthalmic findings in Charge syndrome, and in optimizing the visual functions of the Charge patient on their ophthalmic findings. They also include how to optimize treatment of ocular surface diseases in epidemiolosis, these words, treatment of retinopathy and prematurity, and measurement of intraocular pressure in children. Dr. Donsunu was born in Nigeria. She's enjoyed traveling, cooking, reading, and she loves spending time with her nephews, nieces, and godchildren. Welcome to the program.
Thank you for having me, Alice.
We also have Dr. Basil K. Williams. He is a board-certified ophthalmologist and an associate professor of ophthalmology at the Bascom Palmer Eye Institute at the University of Miami Miller School of Medicine in Miami, Florida. That's Dade County for those, some of y'all. He is the department's vice chair for diversity, equity, and inclusion, and an associate residency program director. Basil specializes in ocular oncology and video retinal surgery and diseases. He completed his residency, video retinal fellowship, and chief residency at the Bascom Palmer Eye Institute, followed by an ocular oncology fellowship at Wills Eye Hospital. He currently serves as the co-chair of the Early Career Section for the American Society of Retina Specialists, the president of the Pan American Ocular Oncology Society, and the chair-elect of the Ophthalmology Section of the National Medical Association. He was born in St. George's, Grenada, and grew up in the Bronx, BK, or the BX. I'm sorry, BX. And his research interests pertain to healthcare disparities, adult and pediatric surface and intraocular tumors, and video retinal surgical topics. Wow. So as you can see, pun intended, our guests are very, very well credentialed and are very, very specialized and knowledgeable about the subject that we're going to be talking about tonight. A couple of things I need for you to do as we're about to move to our guests. Number one, let us know where you're watching from. We'd like to know where people are watching us from all over the world. So please drop that in the comments and drop your city, state, rep your city. Let them know. We've already had Dade County, Cincinnati in the house, Natty in the house. So let's make it happen. So drop your city in the comments. Number two, if you know somebody that needs this information, they may have a child that has some ocular, some vision problems. If you know somebody needs it, tag them, share this on your page because we want this information to get out to as many people as possible. And number three, if you have any questions throughout tonight's presentation, please drop those in the comments as well, and we will get as many asked and answers as possible. Please don't get too specific because they can't, give you, because they have to look at your chart and do a lot of testing for your child. So please don't get too specific. But if you have some questions, please make sure they get asked and drop those questions in the comments. All right. So I know you didn't sign on to hear me talk. Let's let you meet the two smiling faces here that are the most accomplished of the three of us. They're the two most accomplished people on this panel. So thank you. Welcome again for being with us here this evening.
Thank you, Alice. Thank you for having us.
Yeah, absolutely. Happy to be here.
So Dr. Dosuma, first question for you is, how can our listeners know if their baby can or cannot see?
I think that there are many ways they can know. Part of it depends on how old the child is. So I'll quickly run through very quickly what you expect your baby to see. When your baby's first born, really all they can see is, and if there's full term, so we're talking about a full term baby because we don't have as much data that I can share with you on our preterm babies. But really what we're looking at is, can they see light or not? So those are the things we look for right at birth. As they get older, we start looking to see, are they following things? Are they responding more when we do things? Are they blinking to light? And usually right about 2 weeks of life, they'll have small movements back and forth. And then when they're closer to about a month, then you see them where they'll follow. And we talk about that distance from where you feed a baby upwards, and then they can start to see. But really they see black and white. They don't have color. And usually anything after 3 months of life, you start to see your baby reach for objects, and they can have a little bit where they can see that and reach for things. And usually after 6 months of life, that's when you start to see, okay, their eyes are moving together and how they're using their eyes. So that's early. By the time your child is about 1, most children without any other medical diagnoses are crawling or moving around. And really what you should be seeing is the differentiation of objects where they can tell, this is a ball versus a bottle or whatever else they may be reaching for. So those are the things you're looking for. So if you're not seeing some of those milestones, visual milestones, or where they should be at a certain age, we worry. Big things to look for, though, are, I'm really not responding to lights. I'm not looking at a parent's face or an adult's face when I'm being fed. The eyes are wiggling or shaking. That is something else that would make us concerned. An older child, and older for me, because I see a lot of premature babies, 1 to 2, is walking into walls, not responding, not socially smiling, and things of those natures. That would make us worried.
All right. So that was my next question. So are there some symptoms that parents should be on the lookout for if their baby, I heard you say wiggling eyes, not paying attention to you when you're feeding them, or are there some other symptoms that they should be looking for?
So a couple other things that we will look at is if there's a misalignment of the eye. So typically we expect both eyes to be looking in the same direction. Prior to 3 months of life, as babies are learning, they can go out, they can go in, and we're not very concerned. After that, we get worried, and if it's permanent after 6 months, so a big misalignment, that wiggling that you see, that's definitely something else that would make us concerned for a baby. So I'm thinking less than 6 months of life. older than that, if they're not reaching for things, even not reaching to feed themselves, those are certainly things that we would worry. And then we talk about if you take photos of your baby, if you notice that the reflex you get is not your typical red reflex. And there are many nuances to that. I'm sure Dr. Williams will jump in now. But if you see an abnormal reflex, then that makes us worried for something inside the eye. Also, your pediatrician typically, at least from 0 to 6 months, is doing what we call a retinoscopy reflex, and they're looking for a red reflex. And those are things that he or she may see when they do that exam that makes us concerned for an abnormal reflex, but also it can show if there's a big refractive error, which means a need for glasses. And that's another reason to come into a practice like mine.
All
Yeah.
right.
Dr. D'Souza, I think you've done a wonderful job with the explanation. And I think that's really, really valuable. Looking at it from the physician side, one of the things that I see all the time, this is true of both parents, but I tend to notice it more with mom. Mom has an innate instinct as to what's going on. And so what I would say is sometimes you might not identify the findings that Dr. D'Souza mentioned, but you just have an instinct or a feeling that the child is not seeing well. And I would say trust that instinct. Our kiddos, when they're very, very young, don't have the ability to say what they can or can't see. And so they can't explain to you if their vision is not great. Also, as Dr. D'Souza mentioned, when they're very young, they don't have perfectly clear vision in the very beginning. And so if the vision is down in one eye more than it's supposed to be, then as the other eye is improving over time, that may seem normal to them. So they may not even be able to explain to you that the vision is down in one eye. But if you notice any of the characteristics that she mentioned, if they're bumping into things or you get the feeling that something is off, definitely bring it up with the pediatrician. I think being an advocate for your child is extremely important. And then other signs that you want to think about, definitely the light reflex is something that's important. You also want to make sure that the eye color is the same in both eyes. If there's a difference, that doesn't necessarily mean there's a problem, but it is something to pay attention to and something to bring up as well.
So you both talked about that reflex what does that mean for people like me that didn't do so well in science?
Think about the eye like a camera, because that's really what it is. We've got the cornea, we have the lens, and we have the retina. And think about the cornea and the lens like the front part of your typical camera. Now we've all got digital. And think about your retina, think about it like the film. It's going to get light to go in, and that's how we see. So when we shine light in, actually, we get a reflex that comes back to us. So if your camera is clear on every single level, through the cornea, through the lens, and all the way to the retina, you get nice reflex. And our retina has got a pigment that comes back as a red reflex to us.
Okay.
So if there's something in the way, then you don't get that reflex. And just like if your camera has any part of it that isn't clear, you will maybe take a good picture. A baby or an adult's eye wouldn't form a clear picture if there's something in the way. So that's a clue for us.
Yeah, and I think you see it all the time when you take regular pictures, or at least before they had good filters on the cameras, you'd see the red eye in the camera all the time. That's actually a good thing. That's normal. That's what you're supposed to see. That's kind of the reflex that you get bouncing back of the light. So if you have a white reflex, a yellow reflex, or something along those lines, then that tends to mean that there's something in the path of the light that is affecting the color. And so when it bounces back, you're seeing the reflection of something else going on inside the eye, as opposed to just the normal color.
So I was today years old when I found out that red eye was good on those pictures. That is amazing. All right, so that's a good thing that your eyes are reflecting. I'm making a joke, but that shows that your eyes are reflecting the flash that's happening, and it's going in, and that's where the red eye is coming from. And if they're red, okay, good. Your eyes are relatively healthy. I'm not gonna say they're healthy all the way, but they're relatively healthy, getting that good refractory. Okay, that's good. Thank you for explaining that. I know that wasn't part of the questioning, but I just, when you were saying that, I was like, I'm like, well, wow, I don't know what that is. They've said it a couple of times. I wanted to make sure that our viewers know what that is and why it's happening. So that is great to hear that. So you talked about the pediatrician. So what is a pediatrician looking for? They're looking for that, and are they looking for the pupil to dilate when they shine light into? So what are some of the other things that a pediatrician is looking for, especially with the younger babies when they don't have that full vision, complement available to them?
So happy to take this. So the pediatrician is looking for that red reflex. That's one. They're also looking when they shine the light. They're also looking. Typically, what we do is normal responses. If you get light shine, your pupil actually gets a little smaller. So
Right.
they're looking to see if that becomes smaller as a response. That's one of the things. They're also looking if they just shine the light directly to see if the eyes are straight. So sort of like even if you look at me here, if you look, you can see the light right in the middle of both of mine. If one eye was out of alignment, you wouldn't see that. You'd either see the reflex off, depending on if the eyes turned in, out, or put down. So that's another thing that they are looking for when they do that. So they're looking at that reflex, and also they're looking at the pupils, which is the window through which we look through. And sometimes at the edges, you can have changes that may be suggestive of something that is benign or something that could be worrisome in the eye. And they're also looking at that typically.
Yeah, absolutely. I mean, in general, you think the pupils, we all know kind of that black spot right in the center of the colored part of the eye, and you want it to be round and you want it to be symmetric. So as long as the eyes are looking the same in both eyes and they're round, that tends to be a good sign.
So you mentioned before, and I'm going to throw this to you, Dr. Williams, about the eyes being different colored. That could be a sign of a vision problem. Why is that?
Yeah, so normally the eyes are the same color. That's kind of the way it is from a genetic standpoint. If there's a difference in color, there could be something that is growing inside the eye on the surface of the iris. Sometimes that could be blood vessels that can change the shape of the iris. It could be that there is a freckle or a mole on the surface of the iris. There could be a growth of a number of cells that can change the color as well. So there are a few things in there that could be in the eye that change the color in one eye versus the other. It's also possible that it's completely normal and that's just the way your baby is. But in order to be able to evaluate, in order to know that for sure, it's important to kind of bring that up in conversation and have that evaluated on a closer level with higher magnification than you and I can see with just our naked eye.
So what's the youngest that, can a child that young have their eyes dilated? Because I know that's something, so an infant could have their eyes dilated, because I have learned that much, that you have to have that dilation in order to be able to see all the way through. So I'm a parent. I've got a young child. I'm noticing some of those symptomologies that you had mentioned. Maybe they're bumping, maybe they're not. If they're a baby, they're not following me, or they're not, tracking, as you say, properly. When should I know that, okay, I need to take my child in to see an ophthalmologist to get that dilation so they can get the full workup?
I think everything you mentioned would make from our standpoint, would make us worried, and we would say, come in and let's take a look. Provided that it's consistent. Some children will get a fever and they have an ear infection or something, and they will behave a certain way, and then they get better, and all of that goes. But if it's consistent, they're not ill, there's nothing else going on, then they should come in. And to answer the other question, we dilate babies as early as 30 weeks of life, premature babies, because we're doing exams that early. So we can dilate you as early as we need to. The kind of medicine we use is different, but that's going down a different pathway. But we're very specific about what is safe to use based upon how old you are.
Wow. Okay. So, and I'm saying that assuming that the eyes weren't damaged through some sort of physical injury, like a toy or something hitting them in this place. I'm just talking about if they're just do normal activity, they're not, having some issues. I want to make sure that parents understand that there's a distinction if there was an injury to the eye versus something that's coming from internal. Okay.
And injuries that may look superficial still need to come in, though, because they can be something deeper that we need to treat.
Okay. So what are those conditions? And so Dr. Williams, I'm going to ask you this question. What are the conditions parents should know about that are eye and vision related in babies? And then what are the causes and how are they diagnosed?
Yeah, sure. Absolutely. So I think that's a fantastic question. And I think that encompasses a lot of things. There's a couple of things as we've already mentioned, that you notice kind of early on. And so if the eyes are not aligned, so if the eyes are not both looking in the same direction at the same time, then that is something that we call strabismus. And sometimes that runs in families. Sometimes a child can be the first one in the family that has this condition. And I think that's something that's important to bring the child in for, and to not only to see the pediatrician, but also to see the ophthalmologist, because that can happen from a number of underlying causes. I'll let Dr. Desumnu handle a bunch of them, but sometimes that's an indication that the eye is actually not seeing well, and therefore the brain is not working really hard to keep the eye aligned. And so if the eye is turning either in or out because the eye is not seeing well, then we have to do a dilated exam to see what's going on inside. When we see a different color reflex in the eye, this is one of the things that I tend to specialize in because there's a number of factors. So if you see a white reflex, the scariest thing that we think about is something called retinoblastoma. And that is a type of cancer that develops in children. It is fairly rare, but it does make up about 2% of all childhood cancers. And so having a white reflex in the eye does not mean that there is retinoblastoma, but it does mean the child should be evaluated to make sure that that's not what's going on. And so that is one of the possible causes. There are also some other conditions of the retina, and Dr. Desumnu mentioned the retina before. That's like the film of the camera. So that's the movie screen where the image gets projected onto in our eyes. And so if you have disorders of the retina, if there's abnormalities in the blood vessel, if the retina starts to become detached or separate away from the wall of the eye, or other things going on with the retina, then those can also be factors that make you get a different color reflex in the eye. So I think that covers some of the stuff in the back part of the eye, and I'll probably turn it over to Dr. Desumnu to talk about some of the other factors, especially in the front part of the eye as well.
Thank you, Basil. So a couple other things that we look at outside of strabismus is really something as simple as glasses. So children may have like a really high nearsightedness or high farsightedness, and they cannot see. And the thing about it is, as we grow, we learn to see. So if we don't put the right power in front of you to learn to see early in life, even if we catch you later, you may never learn to form that perfect image because your brain has learned, well, I'm always supposed to see blurry. And then it's hard to unlearn that. Sort of like when you learn a language really early in life, you speak it a certain way, it's hard to change how your diction is later. Same thing with vision. So that's one of the things that we're looking for. Other things we worry about in the front of the eye are cataracts, just like adults get cataracts and those have to come out surgically. We also, if there's a big cataract, we'll have to take those out surgically. That clear window on the front of the eye that we talked about, the cornea, we want to make sure that it's clear and that there's nothing affecting it. Other things you worry about, I would take my glasses off. Some children will have a droopy eyelid. And you can imagine if you're learning how to see, but you've got something that is in your way, your brain won't learn how to see. And your brain will say, well, when I try to reach for my mom, I can see her with this eye, but this other eye is covered. So I'm just going to turn off this eye. So the brain actually shuts off the vision. In addition to something blocking it, it shuts it off. And then that's something we have to reverse quickly. So unlike an adult who may get a misalignment of the eye later in life and they complain about seeing double, children don't complain. They actually do see double. And that's too hard for them to reconcile. So what the brain does, it says, I'm going to turn off one of the eyes so that I'm not going around seeing two or wobbly because I can't explain it. And so the eye then doubly doesn't see, it's turned in, but then the brain shuts it off too. So that's a reason to catch it early so we can make sure we turn that on, because after a certain age, there's nothing we can do to turn that back on fully, unfortunately. So those are really, really big things that we're looking for.
Wow, I'm learning here because I'm like, okay, your brain, it's like a supercomputer for the body. And it's just like, all right, yeah. So I'm learning it's AI. All right, maybe that's really, not artificial, but just intelligence, intelligent design. Maybe that's ID. So let me get this right. So if there's some vision impairment, your brain's going to be like, all right, it's not learning how to see properly, whether it's blurry or you've got something that's partially blocking that vision. It's like seeing half the room or something like that. Your brain's like, all right, let me go ahead and shut that off so I can get the information that I need from this other eye. And that's not good because we want to have two functioning eyes. And so that there needs to be an intervention, not only from the parental side to be able to get the child in to see an eye specialist at that point in time, because I guess delay is going to cause that problem to where it can't be reversed. Like I did feel a little bit bad when you made your language example, because I'm like, I guess the Southern tongue is going to be Southern my entire life. So I'm not going to be able to learn how to speak anything differently. All right. I got to live with it. It is what it is. All right. So you just told us about the conditions, and thank you for that. So what are some of the treatments? What are some things? I know you mentioned if there's a cataract, there's got to be some cataract surgery for that. Are there any other treatments for the conditions that you just talked about?
Yeah, so if for the conditions in the back part of the eye, I think it requires a very, very good examination. And I must admit that with many adults, it can be hard to examine the eyes, especially young men, because they don't like to keep their eyes open with the bright light shining in. And it's that much more challenging when you have kiddos, because either they can be scared of someone that they don't know coming close to them with the light, or the lens or something along those lines. And so we do the best job that we can examining children in the clinic. But there are some times, especially when there's things going on in the back part of the eye, that it requires us to take a deeper look. And sometimes that requires us to use anesthesia. So that way the kiddo is relaxed, so we can get a good look at everything that's going on inside the eyes. It can also be helpful for us to get pictures, because sometimes pictures show things that we can't see when we're looking ourselves. Sometimes that's regular pictures, sometimes that's pictures to look at the blood vessels. And in order to do that, sometimes we give a medication in the IV so we can look at the blood vessels to see if there's any leaking or any other abnormalities with the blood vessels. Depending on what we find, so if there's inflammation in the eye, then usually steroids is a medication that we can give, usually drops of steroids, sometimes oral steroids, it depends, to help get rid of that inflammation. There are obviously potential side effects, but we kind of think about the risks and benefits and weigh that together to make sure we're giving the best treatment possible. When we look at the retina, if there's damage to the blood vessels or damage to certain parts of the retina, sometimes it requires us to look at the blood vessels, and sometimes it requires us to treat the blood vessels. That can be sometimes with laser, sometimes with freezing treatment, sometimes even injections of medication into the eye. There's never been a person that's heard about injections into the eye and thought, oh, that's great. That doesn't happen. But the medication works really, really well. And in actuality, it's not a painful thing. So adults get injected in their eye all the time. We give them good anesthesia. Kiddos, we usually do this under anesthesia when they're very, very young, and the medication works actually quite well. And it's not something that, that tends to be traumatic or painful. So I think that's also important to know. With the other condition that I mentioned, retinoblastoma, quite rare, but the thing that we think about as the most concerning, the childhood cancer, sometimes that requires chemotherapy. There's a number of ways that can be delivered. Sometimes it goes throughout the entire body. Sometimes we can actually deliver chemotherapy that goes into an artery, and we actually direct it all the way up to the eye and give the chemotherapy directly into the artery that goes to the eye. Sometimes there's other treatments required like laser or freezing. And I think kind of having that conversation with your doctor about the most appropriate treatment for your baby is extremely important. But at least for the conditions in the back part of the eye, these are a number of the treatments that we use.
Yeah, we do we're in season, kind of our second series with Dr. Joe Coney about diabetic retinopathy. And he talks about that eye shot all the time on a regular basis for the treatment. And I'm just like, maybe I've seen too many horror movies, right? Where where that's like one of the tortures that you see. It's always some needle getting stuck in the eye. And like, you got that in your mental image. You're like, yeah, I don't think that's a good thing. But I get it. Because when you're talking about, so I'm hearing some similarities when you're talking about pooling, the blood vessels, getting things shredding. So I'm thinking about maybe a child that has type 1 diabetes, that could potentially that retinopathy could become problematic and have an impact on their vision, because those blood vessels those secondary blood vessels start to form, shred, pooling happens, and then we kind of have some impairment of the vision. If you're not seeing an ophthalmologist on a regular basis, then that could really have a significant impact on their vision. But if you can catch it early, you can kind of preserve the vision. See, I've been learning. I've been paying attention. I've been trying to learn. But no, that was one of the things that I was thinking about that as you were talking about the treatment options. I am marveling at the modern medicine to be able to deliver chemotherapy directly into the artery that goes directly to the eye. That is fantastic, because I mean, you think about just 20, 30 years ago, you'd have to go through this whole kind of body destruction, that happens with chemotherapy.
Absolutely. I think it's a huge improvement that we have. Number one, it delivers a higher concentration of medication to the eye. Number two, it kind of focuses on the eye. So you don't think about the same amount of side effects that you get in the rest of the body. So you think about chemotherapy and you think losing your hair, perhaps affecting your growth for a period of time, decreasing your blood counts, or various other things. And this kind of approach actually reduces a lot of those potential side effects. So it's a really exciting time to be an ophthalmologist and treat a lot of these conditions, because we do have some modern medicine that is really helping us out a lot. I mean, I think Dr. Desunu can talk about this, much more as well. It's really fantastic the way we're using telemedicine and teleophthalmology, where we can actually take images in certain hospitals or certain parts of the country where they may not have all of the specialists as other places, and they can send those images so they can be evaluated. So if you think that you live in a very rural area that may not have a lot of highly specialized people, that doesn't necessarily mean that you can't be diagnosed and then be treated appropriately. So it's a very exciting time to be able to use the technology we have, both for diagnosis and for treatment.
Correct. Yeah. I just wanted to jump in and say other treatments that we can do for amblyopia and for strabismus. Sometimes it's just glasses. So something as very accessible, at least in this part of the world, as glasses can fix that. When we talked about amblyopia, where the brain is turning things off, sometimes wearing a patch, which children do not love. So any parent out there, it's worth the effort, but just wearing that then forces the brain to sort of turn on the vision in the other eye. Thinking about modern medicine, sometimes your doctor will prescribe an eye drop that will make the stronger eye blurry, which in turn would force the other eye to work, especially for your toddlers who you can't really leave a patch on because they'll pull it off.
Right.
So there are many different things, contact lenses too. We talked about cataract surgery for children, which are very different from adult surgeries. And we can do surgeries to align eyes that are out of alignment. So there are really, really many different things, depending on exactly what it is. But for the amblyopia, I think it's really important to emphasize glasses and the amblyopia treatment with either the patch or the eye drop.
Yeah, I think one of the most important things about this is, as a parent, you are paying attention to how your child is responding to this treatment. And imagine yourself that you have one eye that sees very well and the other eye does not see very well. And if you put a patch over the eye that sees very well, I know some adults that would kind of throw a tantrum, but kids will definitely throw a tantrum in that situation. And it's important as a parent to keep in mind that you're doing the best thing for your child in the long run by keeping that patch on as long as is instructed by the doctor. It can be a little bit challenging for the house because when your child is upset, it kind of makes you, it prevents you from doing other things that you would want to do. But in the long run, that's going to be better for them and help their vision. And so you're not torturing your child by doing that. You're definitely helping them.
Yeah.
And I'll speak on to the parents directly as a parent here, and to say, think about how dependent you are on your vision, right? In terms of your being able to fully function in society, do your job, whatever. Most everything we do, from either eating properly to be able to receive the fork, pick it up, put the food in your mouth. There's a lot of things that are dependent upon our vision. When that is disrupted, think about your child and how disruptive that can be to them really developing along a traditional course. I don't like the word normal, so I'm going to say a traditional course of life. And then their overall quality of life can become impacted or impaired as a result if their vision is not as healthy as it can be. And so when we're thinking about some of these treatments, we're hearing about these treatments, some of them can sound distressful, because I'm going to have nightmares about that needle in the eye situation. But what is going to be even more distressing is having a child that has impaired vision throughout their life. And because I can tell you, as a 7-year-old man, your vision doesn't get any, it doesn't improve over time. It gets more challenging as you get older, and you should know that as an adult. And so therefore we want to give our children the best head start as possible. And these treatments are for that. So, I tell my wife this all the time, especially when we have different things going on. I say, temporary problem, temporary problem, long-term solution. Right. And so let's make sure that we have it in the right context. So this problem, that patch, is a temporary problem, but it's a solution that's going to be helpful in the long term.
Correct.
Absolutely.
So what are things about the eye exam and treatments that a parent should know beforehand? Right. So, you talked about some anesthesia, because I've done some consulting with dentist offices, and some of them had to get the laughing gas in order to get the treatments done. I'm borderline that way too when I go to the dentist. So what are some things that parents should know about an eye exam and treatments beforehand?
Yeah, I think the first thing any parent who's coming in to at least a clinic of mine is time and patience. It takes a while to examine a child. Unlike an adult who's going to sit in the chair, read the eye chart, and you can move through, it's different for a child. Sometimes you just have to get them even comfortable before they'll come out of their shell and even look at what you need them to look at. And sometimes for us in peds, just watching how the child behaves gives you a lot of the answer. I could be playing with a child who looks like they're fine, they're watching Mickey Mouse, and then I go to cover one eye, and then the child just throws a tantrum. And that tells me that I covered their better eye sometimes. And sometimes it could just be, I don't want you in front of my face. And that's why that's why I have to then maybe do it 3, 4, 5 times, which may be upsetting, but then I then really separate. I really think when I cover that eye, I get that reaction because the child can't see. I've covered their better eye, and that gives me an answer. But you can imagine if I have 10 children to see in like a period of time, and I have to do that for every child, and then they have to get drops, and then drops take 30 minutes. We have to give them special drops so we can measure the glasses without getting that input. The better 1, the better 2 children cannot do that. So they have to wait. But that's time. And then when you come back, they're blurry, they can't see. We've got headlamps and lights, and it's all can be overwhelming when you look at it from this perspective of a child. I'm a tiny person. There are all these people coming into my personal bubble. So I try to sing and play and do everything else. All of that takes time, but with a lot of patience, you can get through the exam. And as a parent, I can't imagine just waiting and being anxious and wanting an answer. And I think the other thing is being patient. The patching works. We know that, but it can take time. We tell our parents 9 to 12 months of patching. That's a really long time when you've got a toddler. But when you have a child who's 20/20 and decides they want to be a fighter pilot in the future, and they can walk into that exam room and take that exam and pass and be able to do it because we made an investment when they were 2 or 3, there's nothing like that, honestly. So I think that's, for me, it's just patience, knowing that little investments now, huge potential in the future.
I love that.
Absolutely.
Patience.
Yeah, definitely. And I think one of the things about the exams that we do on kiddos is that, as Dr. Desunu mentioned, they can get scared when there's a bunch of people that they don't know who are coming towards them, especially coming towards their eye, where everyone's natural reflex is to kind of protect your eyes. And so I think it's important for parents to know that the vast majority of stuff we're doing does not hurt. Many times that the kids are crying, it's because they're scared, or they're annoyed, or they're tired, or they don't necessarily want to be there, but it's not an indication of what we're doing is hurting them. And I definitely have seen some times where I'm going to examine the child and the child is crying, and I can see some tears from the parents too. Some of it is anxiety about what's going on, but some of it is like, oh, is my baby hurt? Like, what can I do to help them? And I think there's a couple of things that can be done to help in that situation. First, figure out the best mode of communication for your child to try and relax as best as possible. You know your child way better than we do. Dr. Dasunu sings. Everyone in here definitely does not want me singing to your child, but I do the kind of fun, playful things that I can to try and lighten the mood in the room. Sometimes we'll play videos, or we'll play music, or child songs, something that might be their favorite. If they have a pet that they like to keep with them, or a blanket or something along those lines, it's helpful to have those comforting things to make sure the child feels as comfortable as possible. And for you as the parent, the less anxiety you demonstrate, the less anxiety your child is also going to demonstrate, because they can actually feel when you're nervous, and they're like, well, if mom or dad is nervous, then maybe I should be nervous too, because something is going on here that they don't like, and I shouldn't like it. So I think trying to transmit positive energy and trying to comfort your child, trying to explain to them, depending on their age, about what's going on so they're as relaxed as possible, I think that also goes a long way.
Yeah, my training was in mental health, and I will echo everything that you're saying. Your child is they're watching you, right? And they're watching you for how to respond, how to interact. Is this person safe? Especially with younger children. And the more what the energy that you're putting out, as we say, the energy you're putting out, they're receiving, and they're picking it up, even the things that you don't think that you're putting out. If you're over there and you're trying to put on a game face, but when you walk away, you have anxiety. They feel that too. And so they're actually more intuitive a little bit than adults are, because that's how they interact with the world, is more through intuition than through cognition and logic. And so when we're doing that, we've got to come to grips with it. We've got to come to terms with it. And I think the best thing for parents, whether you're a single parent or if you have a partner, is to practice away from the child, right? Go through those emotions on your own, that your child may have some vision problems, and that tomorrow is this procedure that's going to get done on your child. Go through those emotions, so therefore when you're there in the moment, you're not experiencing it firsthand. Try to mirror that, go through it, so when your child's looking at you and you're like, okay, it's all good, it's fine. The story I always share with folks is, I remember we're having our first child. We were going through natural childbirth. We did all the Lamaze classes. In those classes, was much like I am right now, kind of playing around, joking. I'm like, why are we here? It's every night, whatever, but I'm paying attention subtly. We get to the point, doctor says, okay, it's time to push. Wife freaks out. Has that moment, right? Because now it's the moment the child's been born. I snap right in. Oh, no, tuck that chin. Let's get this leg up. I grabbed the leg, told her to tuck her chin and push, right? We're going to push. And she said, just that moment of seeing how calm I was and responsive, she calmed down, and we were able to have a natural childbirth. Child was healthy. Everything's great. She's about to graduate from college this year. So, but again, that's reading the response of the person that's closest to you in that moment. And that's what the children are doing. And so we have to, as parents, control that so they have a better experience with you all. But you sing, like I said, Dr. Williams, maybe you bust a rhyme or something like that. Maybe
I can carry a beat.
Okay. All right. So we're here on blackdoctor.org. If those of you don't know, we're talking to Dr. Susumu and Dr. Williams all about your child's vision. So you say, hey, title of this program is My Child Can't See. What can I do? But as I said, we're on blackdoctor.org. And so the question is, are there any racial or ethnic differences when it comes to these conditions that you've been talking about? Is there something that we know there's a health disparities across the spectrum of conditions? Are there some disparities in here? Are there some differences that our parents that are watching this should know about?
Yeah, I think that's definitely true in a number of situations. I think more recently, we've actually started to look at some of the data, which I think is the most important thing. If you don't look at the data, you have no idea what the numbers are, and it's impossible to tell if there are any differences or any things that we need to pay attention to. When we look at the cancer world, and I bring up the cancer thing a lot because that's one of the main things that I do, we see that children who come from Black or Hispanic backgrounds are more likely to have their eye removed than have other treatments for cancer.
Okay.
Some of that is because of the time of presentation. And so I think some of that is related to access to care, being able to get in to see your doctor, the costs that are associated with that, being able to get time off from work, being able to figure out transportation to those appointments. Some of that, truthfully, is interacting with your pediatrician or ophthalmologist and making sure that they're hearing what you're saying and not kind of brushing it off. And so, I wouldn't necessarily go into the doctor with the attitude that they are not going to listen to you, but I would go in with the perspective that you are going to be an advocate for your child. And if you see and know that something is going on, and let's say you're with your pediatrician, and you say, well, this has been going on with the eye for a little while, and they say, oh, don't worry about it, we'll see you in XY number of months. It might be valuable to say, I would love to see an eye doctor just to be sure. There's no downside to having that appointment. And so I think kind of advocating can be a helpful way to try and reduce some of these disparities. And so there are also disparities in a number of retinal conditions in terms of surgical outcomes, and things along those lines as well. So I think it's something that we have to be aware of. We have to be aware of access. We have to be aware of going into the doctor, of advocating. I think one of the other challenges that we've seen, and I think everyone's kind of working on this now, when we talk about technology, we talk about artificial intelligence, and we talk about taking a photo and having artificial intelligence look at that photo to recognize what's going on. A lot of the algorithms used to train AI has been on children of less pigmentation. And so seeing eyes that have greater degrees of pigmentation, it may not be able to identify what's going on in those eyes as well. And so we are now working on the data sets that train the AI to make sure that they come from diverse backgrounds so we can actually get information from all types of groups. So there are some challenges, of course, but we're definitely working really hard to reduce the disparities. And I'm actually, again, really excited to be in ophthalmology and in healthcare at this time, because I think this is something at the forefront of what we're doing. We're paying a lot more attention to it, and we're actually working on a lot of these things, much more so than some of the lip service that has been done in the past.
Yeah. I think from my perspective, in terms of what I do, is really the screening and getting the children in time. Like Dr. Williams has said, just as we don't screening time to get our children in for retinoblastoma, we're sometimes not screening to get them in time for refractive errors, for strabismus, and for, amblyopia is the number one leading cause of vision loss in adults in the developed world today, and it's very treatable. So it's the same thing. So I tell my families, we are also here to advocate for you. So it's asking for that. At my hospital, if you come in and we can demonstrate that there are limitations to getting glasses, and the beauty of glasses is they help you see. The disadvantage is they're breakable. So if your insurance is going to buy your child something like mine, plastic, they'll break. So oftentimes insurance won't cover a little bit more for the malleable, flexible ones that wouldn't break. At my hospital, we've actually developed a fund where we'll help fill that gap. So you're not going through multiple glasses with a 2 or 3-year-old. Hopefully you get one. They're malleable. They can throw them off. They can have their tantrums. But when you put them back on, they work. So I think it's really, really important to ask for that. But that's one thing we're seeing in my clinic. My patients who are coming in where we're not getting those excellent outcomes, despite having data for years, tend to be our patients in our communities, and part of it is just limited access to what is needed. So just working with that.
Well, yeah, I'm feeling it. It's sad, and what I hear is, we hear the terminology social determinants of health, right? We hear that a lot, and that's what you're hearing. And what I'm hearing in that is kind of that umbrella and social determinants of health and all those things fall underneath that. Second thing is there's a true mistrust and distrust of healthcare systems by communities of color. And distrust, we like to lean in more towards distrust because distrust is based on something that's actually happened versus mistrust is kind of suspicion. Distrust is something that's really happened. And so there has been some abuses to people of color by healthcare in the past and even some currently. And so that causes us to delay going in. And that delay is where we're talking about those amputations. Those amputations can also be made because they're like, well, how likely is this person to follow up, right? And that's another big determining factor.
Mhm.
So they say if this child, parent's not going to be able to bring this child in on the regimen that they're going to need to for this type of treatment plan, the easiest thing might be to do is just remove the eye, and then therefore we can eliminate that. Now, that's not taking into the account the long-term implications of now having one eye, but that's how it's determined, and that happens in diabetes when we're talking about the amputation of limbs versus using other methodologies to preserve the limb. That also comes into play. And so what I'm speaking to the audience more so is that we play a role in how the decision that's being made, and that role is how soon we present with conditions, and how often, and how our follow-up is. Those things, those factors that we can control are going to go a long way into the outcomes in the treatment plan that is diagnosed for ourselves or for our children.
Alice, can I add to that? I can speak for children's hospitals. I cannot speak for private practices. Every children's hospital has a social worker, and you can come in and ask to speak with a social worker, with a caseworker who can connect you with sources. So that I can speak for children. And oftentimes you can then get that advocacy and, getting an Uber to the appointment, getting help with the glasses, getting help with getting patches. If you live in the state of Ohio, we will mail patches to you for free. And I say we because it's actually a program run by the whole state of Ohio. I happen to just sit on that board, so I can say we, so not under the umbrella of my hospital. But there are things like that can be done, and I can speak for children. Certainly, I know that things are different in the adult world, and I don't happen to see adults. But a children's hospital will have advocacy. I think part of it is just really putting your hand up and saying, I really need this help. How can you help me?
Yeah, that's super important. Do not be shy. Do not be embarrassed. You are doing this for your child, and there are resources available to help take care of them. And the only way you will get them is by reaching out and asking for them. So I think that's extremely critical. One more point I wanted to make briefly is that sometimes eye removal is the most appropriate treatment. Sometimes that will save a child's life. And so that may not be in our minds what we're desiring. And sometimes if the child was brought in earlier, maybe that wouldn't have been the case. But much more so than parents, children are extremely resilient. Children are able to navigate so many challenges that we don't necessarily think they can, and they can actually grow up and have a completely normal life doing everything that they want to do. And so, I think it's just important to keep in mind when we're thinking about treatments and how it's going to affect our kids and how it's going to make them look cosmetically in the long run. Kids actually end up doing very, very well. And again, we've had a lot of improvements in technology. The idea of removing an eye used to be like kind of a glass eye that may not look in the right direction, et cetera, et cetera. Right now, the technology is fantastic. So you can barely even tell if an eye has been removed. And just wanted to throw that out there.
No, that's important, because again, it's about how we respond to it. So if that is the case, if that is the best option available for the child is the removal of the eye, how we respond to it as the parent goes a long way into how that child is going to respond to it. If we try to make it like it's a handicap and baby them, then they're going to always feel handicapped. But if we say, hey, look, no, you can do it just like any other child, then we build that into them. We pour into them that they have these same abilities as everybody else, even with only one eye, and then they can go out and achieve the great things that they can in their lives without seeing that as a handicap. So you're absolutely right. And if that's the plan, that's the plan, and we have to deal with the hand that we have to, play the hand that we're dealt. So Couple more questions as we're wrapping up here. This has been a great discussion. I've been dropping some resources for our audience members. I've been dropping a lot of resources there in the comment section on a number of conditions from our partner websites. We've got the American Academy of Ophthalmology, the American Academy of Pediatric Ophthalmology and Strabismus. And then we also have the National Eye Institute, and on the NEI website, they have links for Spanish speaking as well. And so do not feel encumbered if you are primarily Spanish speaking and need that. They have that available as well. So I've been putting the links there. Don't go right now because we still got a couple more questions, but just make sure that just to let you know that there is a number of resources there available to you after this broadcast. So, Dr. Williams, you alluded to this. What's the future like for children with some of the conditions that we've talked about, where those children have all a part of their sight? It seems like the technology is getting to the point where we can save more vision than not.
Oh, absolutely. I mean, this is such an exciting time with the technologies that we have and the things that we're able to do for kiddos. Going from the 1900s, where it was pretty much eye removal for most people with cancer, then going to radiation, where that had side effects, then chemotherapy, which was better than radiation, and now chemotherapy that's directed towards the artery. The level of vision that kiddos are able to have from a cancer perspective is honestly unbelievable and continues to improve. In terms of a lot of our retina conditions, we have better technologies to diagnose things earlier. The injections of medication, I mean, they started coming to market probably in the early to mid 2000s. And since then, we've had a number of new medications that have come out. And so that's also changing the game in terms of how we're able to deal with blood vessels that are affected inside the eye. Our surgical techniques have been changing dramatically and improving. Our equipment is getting better. We haven't talked a lot about inherited retinal diseases, but diseases that have been passed down from parents to kiddos. We used to just say, well, it's going to affect your vision and it's something we'll watch year after year. Now we have medications where there's gene therapy and various other things that we can do for inherited retinal diseases. So many things that we couldn't do anything for as short a time as 5 years ago or 10 years ago. We now have things that we're able to use for treatment. So it's unbelievably exciting right now.
It really is. And talking about AI, for children with inherited retinal diseases, gene therapy, but even children who've got treatment for different things and we cannot get things better despite our best efforts. We have a lot in the low vision world, pediatric low vision world, to help. Our simple iPads or tablets with, apps in them can help a child navigate. We've got VRs. There's so many different things. So, Basil and I share a few patients, and sometimes we know that we've reached what we can for vision, and then our low vision team jumps on board and does an amazing job. So they're sitting in class. They can't see the board, but they've got technology that puts it right in front of them, and then they can see what the teacher shows. So there's so many things out there.
Yeah, that's fantastic. I'm speaking both as a moderator and as a parent. It's just amazing. And I know when I grew up, it was tough. I remember seeing kids with patches on their eye. I had no idea, and thought about some of the things that they got picked on. Unfortunately, in those situations. And so we've got to do a better job. And the way we do that is by sharing the knowledge, right? So we know what that patch is for. We've got a better chance of being able to overcome some of that. And then just thinking about the kids that couldn't hear well, couldn't see well, are struggling with their physical ability to learn, dyslexia, dysgraphia, dyscalculia, all of these different things that can happen. And that child starts acting out. And instead of getting taken to the principal's office, now we can have some ways, some things that can put in place. Those kids just got put out of the classroom, and they could just be something that could be easily correctable if we took the steps to learn what was happening. So, Dr. Dosumba, the last question of the night is, why did you decide on ophthalmology and to focus on children in your practice?
So that is a great story, a little bit of a sad one, but also good comes from everything, is my opinion. I was going to be a pediatrician growing up. You ask any of my family members, that was me. I love kids. I was always going to do that. And just when I started medical school, one of my parents told me that they were going blind. And it's from something that is treatable. So I thought we were going to get on top of this and gone into med school and I wanted to learn more about the eyes. And so from that conversation to finding the eyes and absolutely falling in love. And the way to put those two together was to still take care of kids, so pediatric ophthalmology. And unfortunately, they've lost all vision and it's not recoverable.
Right.
The good in that is I know that prior to loss of vision, they had a good life
Right.
and they got to see so many wonderful things. And so sometimes Basil has worked with me and kids with worse vision, and he knows I get emotional because I want these kids who are just starting to get to see. If I could go back, I would get my parent their vision back, but I can't. So I want my kids to get to see so that tomorrow they get to see the beautiful life. And so that at the end of their lives, I tell my kids, I want you to see to your 150, and I mean it, that they get to see all the beautiful things life has to offer. And my parent has gotten to see a lot of beautiful things. Getting not to see some right now, but at least can understand when we describe them because had vision.
Right.
How about a child who never had vision and when you describe it, can't get it?
Right.
So hopefully that we all do our part. All of us have got a part to do to get every child seen, every child hearing, and every child live into their fullest potential.
Amen.
Yeah, absolutely. My story into ophthalmology was a little bit more roundabout. When I was young, I wanted to be a basketball player. That was it. That was first, second, and third. I played in college. I played in Europe. And when I came back, when I finally accepted that I was not good enough to make it to the NBA, I was planning on doing finance. And so I was putting together my CV to apply for finance jobs in New York. And a friend of mine's dad was a retina specialist and an ocular oncologist. And they had a tech in the practice quit. And he was like, well, you can make a little bit of money on the side doing this just for a couple of weeks. And then once your CV is together and you have your job, you can move on. And two things happened within the first few weeks of working there. One, there was an 18-year-old that had a large tumor and she had to have her eye removed. And I watched the interaction that she had with the doctor, the way the doctor made her and her family feel outside of the actual medical part of the treatment. And it kind of blew me away at how much of an impact you could have in that kind of situation. And then the second thing was actually very simple. I saw an older Black woman who had diabetes, and I prepared her for the doctor. She saw the doctor, and then on her way out, she did one of these things, which now I'm quite used to. She kind of like looks around, she sees me, she pulls me to the side, and she's like, I just want to thank you for being you. And it's been so long since I've had an opportunity to see someone like you in this space. And that really stuck with me because it made me realize not only the impact that we could have by taking care of certain disease processes, but also by nothing outside of being who I am, trying to provide a little bit of extra comfort and safety to somebody who is coming to a scary situation. And going to an eye doctor if you're losing vision can be a really challenging and scary thing. And so I think that kind of directed me towards ophthalmology and towards ocular oncology. And seeing that kind of impact, I felt that there was no better way or no more significant impact that you could have by also trying to take care of kids because of the impact that has on families. And so that's kind of my path, a little bit roundabout, but definitely allowed me to learn and develop into who I am. So excited about it.
Well, you two have been a hit with our audience from all over. We have people watching from Nigeria, from all over the world, and everybody. Our YouTube audience has been great. Our Facebook audience has been fantastic, and just you're absolutely right. And we know the statistics that when Black patients see doctors of color, their outcomes are improved markedly. And so we have to make sure that we keep the pipeline open for the creation and practicing of more physicians of color. And so we're doing our best here. I just want to say thank you both for standing in the gap for parents and the children. This has been a fantastic program. Yes, so there's a question. You can find this program. It's going to live on the Black Doctor Facebook page as well as on our YouTube channel, so you can go back and watch it. And we'll create a playlist of all of the vision health programs with our partners at the Children's Vision Equity Alliance any eye. So we'll have a playlist so you can watch them all. If you want to learn about glaucoma and cataracts and all of the different things we talked about, fireworks and safety when you're playing sports and all of those things in between. And so we just got a vast assortment of programming there. So again, I want to thank all of our partners. I want to thank the two of you for just being so gracious and dealing with me and my dad jokes and everything that we've been going through tonight. But thank you all for watching. Please like and share this program. We want to make sure that this gets out to as many people as possible. And that's why we keep it conversational. We keep it fun because it does not have to be heavy. We're talking about something that is important to you, but your health does not have to be heavy. Make it part of your life. Get your eyes checked, whether you're an adult or a child. If you're above the age of 40, you should be seeing an ophthalmologist at least once a year, particularly if you are a diabetic. And we know that there's a large number of African Americans that are diabetic. If you're not diabetic, you can work that out with how often you should go get a dilated appointment and exam, but you should get a dilated exam if you're over the age of 40. I believe that's the screening guidelines of late. So please go get checked, take your children, pay attention to what's going on, and at risk of sounding another pun, we'll see you next time.
Thank you.